Okay. Welcome everyone. I see people are starting to log on. We'll give everyone a few minutes to join in. Thank you so much for attending tonight. Okay, we've got a great group so far. I'll give 1 or 2 more minutes and then we'll get started. All right, thank you everyone so much for joining us tonight. I know that talking about a pandemic at the end of your long workday doesn't always sound like the most appealing thing to do, so I really appreciate everyone making the time. And if this is your first Ask a COVID Expert event, welcome. If it's your second, then welcome back. My name is Lily Wasserman. I'm the Development Director here at KCAW Raven Radio. I had the idea to do this event because I found that I had so many questions about the pandemic. Everyone I knew had so many questions about COVID, just like personal questions about best practices for safety and how to live our lives. And I felt like I could watch the news all day, read as much as I wanted, and I still was left with so many questions. Obviously, our reporters and the media often have access to authorities in the field, but the general public doesn't always or doesn't have that same level of access. So this event was a way to make experts more accessible so we could get those questions answered, especially with the holidays coming up. I knew lots and lots more questions were coming up for people. And I hope that with this event, you'll be able to get some of your questions answered and also learn from the questions of others, because I know that so many of us have the same questions. In a minute, Martha will go through some of the nuts and bolts of kind of how we'll structure the evening and make sure that we can all get our questions answered. Before we get started, I want to quickly thank the Alaska Community Foundation, who has supported this series, as well as all of our members. And if you're not a member of KCAW, but you would like to become a member, visit kcaw.org/donate. We have a pledge drive coming up as well. If you want to wait till December to become a member, you can do that as well. And if you're joining us from another Coastal Alaska station, welcome. And I hope you're supporting your local Coastal Alaska station. You probably are. So without further ado, I will hand it over to Martha Pearson. She hosts our awesome program, Health Chat, and is the Director of Health Promotions from Search. So take it away, Martha.
Thanks, Lily. Thanks, everybody. And this is the second Health Chat, Ask a COVID Expert, that I've been able to facilitate for Raven Radio. And I'm also a Raven Radio member. So I'm glad you mentioned that, Lily. It's a great reminder to get your membership in. Tonight, we have a series of questions. Those of you that are logged on may have submitted questions, and we have those listed out for Dr. Hennessy to answer. And we also have the option of the Q&A button that's at the bottom of the Zoom screen. I see someone has already put a question in. That's fantastic. So if you think of a question while the session is going and you want to make sure it gets in, I'll be watching the question and answer and helping Dr. Hennessy to get the questions answered and asked online. So thanks for that, and we will get started. I'm going to let Dr. Tom Hennessy introduce himself, and we can take it away.
Great. Well, thanks, Lily and Martha, for inviting me to participate in Raven Radio's Zoom call about Ask a COVID Expert. And thanks everyone for joining. It's an honor to be here and look forward to your questions and having a chance to discuss the situation in Alaska and try to clear up anything I can. I thought it might be helpful to hear a little bit about my background and why I can speak to you about this today. I'm a medical doctor. I was trained in family medicine and also in preventive medicine and worked in primary care for 7 years before I had a big outbreak come to the community I was working in on the Navajo Indian Reservation. And the outbreak was a brand new disease we'd never seen before in the world called the hantavirus. And it infected young people and caused pneumonia and killed a lot of people on the Navajo Reservation. And so I got involved in the middle of that in tracking that outbreak down and taking care of the patients in our hospital, and became really interested in these new emerging infectious diseases. And a year later, I found myself retraining and going to the US Centers for Disease Control and Prevention, the CDC, and entering into their training program for epidemiologists, and added a master's degree to my medical degree, and kind of changed my whole life, and have been working in infectious diseases ever since then. I worked for 25 years as an infectious disease epidemiologist with the Centers for Disease Control. So I was a disease detective. I studied infectious diseases in populations, did research on them, tracked outbreaks, took care of patients, was involved in a lot of different aspects of that. And most of that time I lived and worked in Alaska. I've been in Alaska the last 22 years. I live in Anchorage, and I was the director of the CDC's field station here called the Arctic Investigations Program. And we help the state and the tribal health system deal with infectious disease threats in Alaska. And we also work internationally to work with partners around the world. So have had a lot of experience with infectious disease threats in Alaska, but because I worked for CDC, I also got involved in some of the big national and international outbreaks. So after the 9/11, there was an anthrax attack in the United States, and I was called into action there and worked for many months on that response to that anthrax attack, trying to help public health departments deal with that. Also, when the SARS outbreak happened, the first coronavirus that really swept around the world, we dealt a lot with that in Alaska and did a lot of quarantine and checking passengers coming into the various air terminals, and was involved in that. As well as the 2009 influenza pandemic, I spent a lot of the year at CDC headquarters working on that. And then in 2015, I went to Sierra Leone and worked on the Ebola outbreak on the ground there, and did on-the-spot research and case investigation. And so have been involved in the middle of some pretty big events and had experience working with these outbreaks, and then also working on the research side of it. So in 2019, I retired from CDC and was kind of minding my own business. I teach a class at the University of Alaska Anchorage in the master's program in public health on infectious diseases. And I was doing that last winter, and we were watching very closely what was happening with this coronavirus. And then in March, I got asked by the mayor's office in Anchorage to help advise the health department there, and also by the University of Alaska president to give advice to the university. And so my retirement plans got foiled, and I failed at retirement, and have been really hip deep in working on the outbreak response in Alaska ever since then. And so I've had a chance to learn a lot about this, see how it's played out in the state, and involved every day in these conversations. So one of the things I don't do is I don't see patients with COVID, and I'm not involved in clinical care. So if people have specific questions about clinical illnesses and all, I'm probably not the best person to answer that, but I'll try to give guidance where I can. So I'm really much more involved in the public health response side of it, and tracking closely the science and all. So that's a little bit on my background and what I bring to the conversation today. And Martha and Lily and I thought it might be helpful if we gave just a bit of an overview to people in on the call today, just to get us a touchstone about where we are in Alaska and kind of what the situation is. So I'm going to share my screen now and just give a short presentation, maybe 10 or so minutes, about where we are in the state and kind of what we can look forward to in the next coming months with the epidemic in the US. So let's see if I can get this thing to move on down. So I'm going to talk about a little bit about the background and how we respond to pandemics, a little bit on the current situation of COVID-19 epidemic in Alaska. I'm going to give an update on COVID vaccines because that's the new big news, exciting news coming ahead. And what can we see in the months ahead, some predictions of that. So this is a graphic, sort of a timeline of the basic timeline for control of a pandemic. We do a lot on the preparedness side to get ready. If a new disease pops up and there's just a few cases, we try to control it. If there's local transmission, we try to control it more. But now we're really in the phase where there's widespread transmission all over the United States and the world, in which you're going to try to get it under control and then get it to decline and then get back into recovery phase. So that's sort of the different phases of a pandemic. And the basic elements really are these six. The first of all is to develop a kind of controlled, coordinated response, which we have in the US and definitely have in Alaska. Lots of coordination going on, lots of people working very long hours to try to make sure we're prepared and responding to it. So that's happened. Then we try to reduce the spread of the virus by decreasing close contact, especially in crowded indoor spaces that have poor ventilation. And then there's a concept of called boxing the virus in, where we use widespread testing to find out who's sick and who's infected. And if those people are determined, they need to isolate. That's what happens with people who are infected. And then the contacts of those people are quarantined. And this is what we've done for really centuries with these infectious diseases. It's the basic way of controlling them if we don't have a vaccine or a treatment. And then a lot of effort has gone into medical case management. Early on in the outbreak, people were dying at a much higher rate than they are now. And we've learned a lot in the medical field on how to reduce the risk and fatalities of COVID. And then all of this is really directed at the stuff below this line here, this red line. We need to maintain essential health services because we've seen in some places like New York City and in Italy, where the outbreak early on just exceeded their healthcare capacity and basically broke their hospital system, where they had to make choices about who got a hospital bed or who went to the ICU and who didn't. And we don't want to be in that situation because it just puts a strain on everything in society. And so that's one thing we're trying to maintain. We're also trying to maintain essential societal services. So we need to keep the water flowing. We need to keep electricity and the lights on. We need to keep groceries in the stores. And if there's too many sick people, we can't do that because the people that provide those services are out and they're ill or they're quarantined. So that we need to keep society going until we can recover enough to get past these things. So those are the basic strategies. Some of you have heard about flattening the curve, and this purple graphic here shows what happens if this pandemic just runs wild through society. It's almost like a wildfire, and we get lots of cases very quickly. And the idea of flattening the curve is to spread those cases out over time, to squish that down so we don't have so many at the same time, so our healthcare capacity is not overwhelmed, and we can keep the lights on and keep the water running. So that's the idea of flattening the curve and controlling the epidemic until help is on the way, until we have treatments or we have a vaccine to prevent infection. And so, you know, a lot of attention has gone into asking people to go into isolation when they've been identified as being infected. And this little graphic gives an idea why we do that. If you could identify this person on the left here who's infected and quickly isolate them, then they can't spread to all their contacts that they would have come into contact with, and prevents those onward chains of transmission. So we're trying to block those. And we've learned a lot about this over the years. And we know that from the past SARS outbreaks that these viruses, these coronaviruses, are really prone to what we call super spreader events. You know, on average, each infected person with coronavirus at the beginning of this outbreak was transmitting the virus to 2 or maybe 3 other people. And that's on an average in society. But that doesn't tell the whole story, because we know these viruses under certain conditions can have one person spread to 20 or 30, not just 2 or 3. And we call those super spreader events. And this little cartoon is actually from the first SARS outbreak in 2003. And these people that are shown in red here were people in Hong Kong and in Taiwan who were the sources of super spreader events who ended up transmitting to other people who spread the infection around the world. So we're really trying to prevent these super spreader events, and we know a lot about them. They happen in closed spaces, poor ventilation. They happen in crowded conditions where lots of people are together. One of these super spreader events happened in an elevator as an example. And they happen under really close contact where people are jammed together. So those are the 3 C's of the super spreader events. We're trying to avoid that. So in Alaska right now, our daily case counts and our rates of new infection are the highest they've ever been in this pandemic. And we moved from what we had over the summer, which was kind of a stalemate with this infection, to increasing rates everywhere in the state. These are the new cases reported by date of a report for the entire state of Alaska. It's just like a little calendar here. It goes from March. We had one outbreak or one spread in the early part of the epidemic, another one in the summer, and now we're into this 3rd wave of the outbreak. So you've all seen those. This is what's going on in Southeast Alaska, and you can see it's following the same pattern, kind of 2 waves with lots of spread, and each of the different colors represents a different borough in Southeast. So you all in Southeast are experiencing something very similar to the rest of the state, just at a lower case number rate. We also track the 7-day average rate of new infections in Alaska per 100,000 population. And we've been doing this for a while just to kind of give people a sense of these alert levels. And when it gets over 10, the alert level set by the White House Coronavirus Task Force is determined that's kind of the high level. So we're over that level in every part of the state now. Our overall rate is 90 new cases per 100,000 people on a 7-day average. So that's a lot of cases, and it really puts us in league with the rest of the US where everybody else is in the red also. Just lots and lots of new cases every day. The other thing we track and pay a lot of attention to is the average number of new infections per case, because it tells us a lot about how we're doing in control of the spread. We call this the reproductive number, and we have tracked this since the early part of the outbreak, and it's shown in this graphic. Again, this is a little timeline from March to November. And currently, right now, each person on average in Alaska is spreading the infection to about 1 2/10 of another person. So that means when it's above the 1, that the outbreak is growing, that each person who's infected not only replaces themselves with another infection, but actually adds to the case counts. And that's why we see that steep rise in the curve. What's interesting though, and what's really important, is that early on in the epidemic, before we started wearing masks and before we were social distancing and before we had a lot of the awareness in the population, our reproductive number in Alaska was up around 2. That meant every case was infecting 2. And actually, after the hunker down and shelter in place last April, we brought the infection rate down below 1, and we were shrinking the outbreak every day. There were fewer cases every day. And that happened also over the summer in the month of August when we were starting to shrink the outbreak. So this tells us a couple things. Right now, the outbreak is in kind of a steady state. We're not doing enough to keep it from growing, but we're not as bad as we were before. And we've seen 2 periods of time in the state when we actually were shrinking the number of cases per day. So that gives me a lot of optimism that Alaskans can change their behavior enough to actually reverse what's going on right now and to reduce the number of cases on a daily basis instead of seeing the number increasing. I mentioned that the red zone is in all parts of the state. The consequence of this is that hospital bed availability is really tight. And that's reduced our ability to absorb any increase in new COVID-19 patients, and a large surge in cases would probably overwhelm our intensive care unit capacity in the state within about 3 weeks to a month. The other consequences has that it puts a lot of strain on the healthcare system because a lot of our healthcare providers are out sick or they've been exposed to COVID and they have to be in quarantine. And also it all has an impact on what other kinds of services hospitals can provide. So this has put a huge strain on our system, and a lot of our actions, both in Alaska and elsewhere, are aimed at preserving our healthcare capacity, and that's tight right now. There is some good news about our current situation in Alaska, that compared to other states, our rate of fatal cases is low. Our rate is about 14 deaths per 100,000 people. We've had a total of 99 deaths. Now, there's nothing to celebrate about any of these. Each of these is a lost Alaska citizen. Each of these have family and loved ones that are behind and are mourning them. And we've lost their talents in society. So all these deaths are a tragedy. We want to prevent each of these. But compared to states like New Jersey and New York, if we had the same death rate in Alaska, we'd have over 1,400 deaths in our state. So we've done pretty well compared to other places. And we actually, among states, we're the third lowest in the US. So that's good. It's a sign that Alaskans have done some things really well. We have widespread testing availability for the virus. The SARS-CoV-2 is the name of the virus, and that's what those tests are done. We've done almost 1 million tests in our state so far. And the turnaround for our tests is about 2 to 3 days, which is pretty good. In some cases, it's even faster. So we're doing good on test availability. Our public health system is working really, really hard. We have enough personal protective equipment available for healthcare providers. We are doing case investigations and contact tracing, although that's very strained right now. And we're close enough that if we could reduce transmission by 15% in our state, we would reverse the current upward trend. So we're within striking distance of actually controlling the epidemic in our state. And the other thing lost in all this, sometimes I forget about it, is that there's this huge worldwide effort to stop this pandemic. The scientific expertise that's being shared, the technological resources that are being thrown at this all over the world are amazing. And we're learning from each other every day. We've never seen anything like it in terms of the collaboration. The whole world is working to stop this, and that gives me great hope also. So the reasons for concern are real. The risk is for getting the infection in Alaska communities is greater now than it's ever before. The epidemic has spread throughout the state and cases are increasing. And we're in winter now and the holiday season, and more time indoors and more time in gatherings. And we have cold and flu season at the same time, where people are coughing and sneezing more and more chances for spread. And our hospital beds and our healthcare capacity is tight, and at some point may actually be surpassed by what's going on. And our public health capacity is really strained. So we're in a really tricky spot right now. And I'd say in a really dangerous spot with hope on the horizon, but people kind of getting fatigued, and we're in a sort of a dangerous point in the epidemic. So there is some good news on the horizon, and it has to do with vaccine development. And this little cartoon shows what's happening with vaccines around the world. Vaccines, when they're developed by a company, they go through different phases of approval. Phase 1, when they might test it just in a few people and look for the dosage. Phase 2, they might test a vaccine in maybe 30 to 50 people to look for side effects. And these big phase 3 trials, which are the ones going on now, are these large scale trials with maybe 50,000 people to look and see if the vaccine is actually effective. There are 6 vaccines that are approved for early use, none in the United States yet, and none of them are fully approved. There's 54 vaccines in human trials going on in the world. It's an amazing amount of work. And in the US, there's 4 vaccine trials that are in that phase 3 standpoint that are testing effectiveness. And one of those is actually submitting information to the Food and Drug Administration this week for approval. So we're in a really, really encouraging spot. I wanted to talk a little bit about the process of vaccine approval and use in the US. When I worked for CDC, I was involved in evaluating vaccines. We did lots of research in Alaska looking at the effectiveness of vaccines in populations. And I was on an advisory committee for immunization practices for a number of different vaccines. So I have some understanding of this working as a federal official. I never worked in the private sector, so can't really speak to that. But there's really 2 steps in a vaccine approval. The first step is the US Food and Drug Administration that evaluates the safety and effectiveness or efficacy of the data. And then they either give a full approval, a biologic license application, which takes many, many months, or they give emergency use authorization, and that's done during a public health emergency. And this is a law that was established after 9/11 to speed up the use of life-saving drugs and vaccines. The same effectiveness and safety standards are used, but it's faster due to a shorter follow-up period for safety monitoring. So after the FDA gives approval for a vaccine, then the Centers for Disease Control and Prevention makes recommendations for how the vaccine is used and maybe how it's prioritized, and then works with states to distribute the vaccine and track how it's used. So these are very well-established processes, and they have been modeled all around the world because they work so effectively in the United States. We have the best vaccine approval and highest safety record of any country in the world because of these longstanding professionals that have worked in this area. So there's a lot of things that are done in vaccine safety monitoring. It's required as part of these trials, which typically involve anywhere from 5,000 to 30,000. One of the trials has 45,000 people in them. And there's an ongoing safety evaluation as part of the trials. And we know this works. For example, the AstraZeneca vaccine, they actually stopped the trial because of a safety concern before they could investigate it. So that's a good sign that the system is working, that if they had a signal that the safety wasn't right, they stopped the trial, evaluated it. They've now resumed that because they determined it wasn't due to the vaccine. After a vaccine's been licensed, there's what we call post-licensure monitoring that's done both by the FDA and CDC. And there's 3 really large ongoing systems that we've had for over 30 years in the United States. And one of those is an ability to report adverse events that can come from the public or healthcare providers, and anybody can report these, and they go right to the CDC and FDA and are investigated. And then there's healthcare systems, mainly HMOs, that include 214 million people in the United States that monitor vaccine safety in their populations that are covered by them. And there's also these big clinical research networks that are ready to stand up and do focused research on safety signals. So if there was a problem with the vaccine, they could quickly mobilize and evaluate those. And we've seen this work because there have been a few vaccines that have been pulled off the market because of safety signals after they've been licensed. So we know the system works, it's taken very seriously, and that's there to protect us. The US government started up this thing called Operation Warp Speed, with a goal of making 300 million doses of vaccine that are safe and effective available beginning in January 2021. Most of the COVID vaccines are 2-dose vaccines, so their goal is to get vaccine available for 150 million people. And this was started to speed up the process, and it was a joint development between the US government and private companies. They jointly developed all the safety protocols, all the effectiveness goals and the monitoring, and set those out. Now, normally those are done by the industry, but in this case, our government stepped in and said, this is how we want you to do this. These are the standards you need to meet. And they all agreed, and that's what they're working under, a similar set of standards. And at the same time, and this really is going to save time, instead of waiting for the vaccine to be shown safe and effective, the US government actually pre-purchased vaccine and encouraged the vaccine manufacturers to make vaccine at the same time that the clinical trials are going on. And that way, if a vaccine is shown to be safe and effective, we don't have to wait for 6 months for them to produce it. It'll be ready to go if a vaccine's approved. And normally a company wouldn't take on this risk, but the financial risk actually was taken by you and me and through our tax dollars. And so that's what's really going to speed up this process if these vaccines are shown to be safe and effective. The Food and Drug Administration has publicly made available their criteria for authorization. And I list them here. I won't go through them in detail, but essentially, because of concern around the election and maybe the vaccines would get politicized, they put out very clear standards of what they were going to be accepting. And the big ones are on the safety side, that they have to follow participants for at least 2 months after the last dose, which really delayed the data that was available, but gave us a better safety margin. They also wanted to evaluate the risk of vaccine-enhanced respiratory disease, and we can talk about that later. They had to evaluate the outcome in people who had prior COVID infection, because I know that's going to be a concern. You know, I had COVID, can I get vaccinated? And they have to continue these trials even after they get authorization. So those were the very clear safety standards that were put out for these vaccines, and what Pfizer this week is going to have to show that they met those standards for effectiveness and safety if they're going to get approval for the vaccine. The implementation of the vaccine would be the next step, and CDC and the states, like the state of Alaska, have been actively planning for this for months now. We know how it's going to be shipped, how it's going to be stored, where it'll be mixed, how it's going to be administered. The contract for the distribution is already in place. We know that most of these vaccines are going to be 2 doses, anywhere from 3 to 4 weeks apart, and there's some really stringent cold storage requirements for some of them. The Pfizer vaccine, for example, has to be shipped at minus 80 degrees centigrade. That's minus 104 degrees Fahrenheit. Super cold, and that's going to really limit who can receive it and how it can be handled. The vaccine prioritization has not been finalized, but this is what CDC has put out as their initial considerations. The first availability of vaccine is going to go to healthcare personnel. Those are the people at highest risk for infection in the US, and that's about 20 million people. So we're going to get our healthcare personnel, including the doctors, nurses, and all the people who work in clinics, vaccinated so they can safely provide care for us. And then we're going to move to adults with medical risks. That's about 100 million Americans. And then there's adults that are 65 years and older that don't have other medical risks, another 53 million. And then there's about 60 million people who are considered essential workers that keep our sewage systems going and the trains running and the groceries on the shelf. And that's going to be the next priority group. So it's going to be done in a series of prioritization steps. And at first, we're going to have very limited doses of vaccine available. But as we get more vaccines approved, we're going to get larger number of doses available. And then we're going to move to the general population. The CDC director estimated that it would probably be, even optimistically speaking, probably not till next spring until the general US population could look forward to getting this vaccine. And again, it's not approved yet, and we haven't proven effectiveness yet. But even if it were, these vaccines were approved in the next few weeks, it would probably be next spring before we had them available. I want to talk a little bit about the possible future scenarios. Some really good work has been done on this at the University of Minnesota at their Center for Infectious Disease Research. Based on past influenza outbreaks, we can expect, if we didn't do anything, that we would have about 18 to 24 months more of this epidemic going on. And we really need 60 to 70% of the population immune to prevent outbreaks and to bring this under control. A best estimate, maybe 15% of the US population has been infected, certainly not that high in Alaska. And so we're nowhere near what we need to control this epidemic in the population. And we don't really want to get there by natural means, because that probably means millions of people would die. So this is what we might expect if we didn't do anything, but we do want to get to about 60% of the population immune. And the pathway out of that is really a COVID vaccine that's safe and effective. And we really need widespread availability in the US and the rest of the world, because we saw how this virus traveled into the United States from China, and then from a lot of people brought it in from Europe into the United States from places like Italy, France, and Spain. So if this virus is running wild somewhere else in the world, it doesn't make us any safer. We really need the world to be vaccinated. And to get there, we need to have public trust and willingness to be vaccinated. And I just did some math for you here. If we had 50% of the population that was using a 90% effective vaccine, and that's about what the estimates are from the 2 vaccines that we've seen some of the data from, the Pfizer and Moderna vaccine, both published results recently that show about a 90% effectiveness, which is fantastic. But if we only had half the population use it, we would get about 45% of our population protected, and that would not be enough to stop ongoing outbreaks of this virus. If we had 70% of the US population get vaccinated, then we'd start to get up in the range where we could see these outbreaks go away and we could start to get back to normal life. Until that happens, we're going to have to continue mitigation efforts. We're going to be playing defense with this virus for at least 6 to 9 more months. And that means until we have a vaccine, we have to avoid the 3 C's, the closed spaces, the crowded conditions, and close contact. We're going to have to keep up the 3 W's to wear a mask and wash our hands and watch our spacing between people. And we encourage all of you to get a flu shot so you don't compound your problems by getting influenza. And some of the other things that I love, these graphics for Alaskans, like Alaskans stand together 6 feet apart. So those are some of the introductory comments, and I appreciate your time and attention for that. And I hope that sets the stage for the questions that you've put into the Q&A and sent us in advance, or for the things that'll come up in the chat. So I'll stop talking now and turn it back to Martha, and I'll stop sharing my screen also. Thanks.
Thanks, Dr. Hennessy. Those are really great visuals, though, and great comprehensive overview. I'm going to look at our question list. We also have some questions in the Q&A that we'll weave in. I'm going to try and batch the questions by type so that we can maybe answer 2 questions at the same time, because many are very similar. Some of the questions that were submitted talking about just some basics about the virus. And if you could speak briefly on how it started and how it is transmitted. There are some questions about this, just some of the origins of the virus and what does it do to make people very sick. So where did it come from? How is it spread? And what does it do to make people sick?
Okay, great questions. This came from China. The first recognition we had of it was an outbreak that occurred in one of these Chinese, what they call wet markets. They're basically a big farmer's market with all sorts of wild things that they sell. And they had the workers in the market, the people, the vendors there were getting sick, and they were spreading it to their customers and patrons. And that happened in the city of Wuhan. And that was the beginning of the outbreak back in January of last year. Perhaps there was some transmission in December. So where did it come from? They've done some sequences now. They look at the genetic sequence of the virus that's circulating in human populations and have compared it to some bat viruses that were isolated in China and found extremely high close relationships with a bat coronavirus that was identified about 2 years ago in the same region of Wuhan, China. And this is what we know about these coronaviruses. They're zoonotic pathogens. They come to us from animals. The original SARS outbreak in 2003 was also a bat virus that spread also through one of these wet markets in Guangzhou province. And it spread to people in the wet market through palm civet cats that were marketed for sale and as meat there. And people were handling them when they were alive and butchering them, and they got infected and would spread it much in the same way that this outbreak started. So we know that these have an animal reservoir and they jump species, and they became able to transmit to humans through genetic mutation. There's another SARS coronavirus that causes really severe disease that has as its intermediate host camels, and it's called Mideast respiratory virus. It was discovered in 2012 through outbreaks in the Middle East. It's not as infectious as this, but is more fatal than the one we're dealing with now. And it originally got started through people who had association with camels in the Mideast. So that's where these viruses come from. Most of the emerging new infectious diseases, including the one I dealt with when I lived in New Mexico, that hantavirus, most of those come to us through the animal world. HIV did, hepatitis came to us through the animal world. These are viruses that jump from one species to another. The way this one is spread, it's a respiratory virus. It infects the upper respiratory tract and the lungs. And so people cough or sneeze or breathe it out in droplets, in respiratory droplets that include mucus and basically spit. So the virus infects somebody, it gets into our respiratory tract, into the epithelium there, and it's shed through there and gets in little droplets that we then either cough or sneeze or sing or yell or speak out. And these droplets, you've all seen those sneeze pictures where somebody sneezes and there's a cloud of yucky stuff that comes out. And those droplets vary in size from big ones that fall on your feet to little ones that begin to float in the air and can travel across distances. We know that from studies in outbreak situations that most of the transmission is in this close contact, this 6-foot window with these immediate transmission of these droplets. Either they land on the person and then they get them in their eyes and nose and mouth and get into our respiratory tracts, or they might land on a surface that somebody touches and then they touch their mouth and then they get infected that way. So they get into our respiratory system through our eyes, our nose, our mouth, and then can infect us. So that's the way they're transmitted. And that's why so many of these measures are about wearing a mask to prevent you from spreading those droplets, and wearing a mask so you don't inhale those droplets, and keeping our distance because we know most of those droplets are going to fall out, and increasing ventilation so that if there are some that are floating around, that they get blown away in increased ventilation. And so our mitigation measures are really based on what we've learned about the science of the transmission of these viruses. And that's where these recommendations for the 6-foot distance, more if you can do it, improve ventilation, more is better, and avoiding really close contact. So, we often say the definition of a close contact is 6 feet for 15 minutes. And that's just sort of a rule of thumb we use. If somebody sneezes in your face, you don't need 15 minutes of sneezing to get sick. You can get sick right away. And if you're kissing somebody, you can transmit it to them right away. It's just that if you're in the same breathing space as somebody, the studies have shown that your risk increases with 15 minutes or more of exposure. There's no magic about it though. Closer contact, longer contact is worse than farther apart contact for shorter periods of time.
Great, thanks. And leading to our next series of questions, there's many questions about mitigation and ways to prevent the virus from transmitting. You've answered some of these with the mask, talking about masks. There's some specific nuances of this though. First question is, mask mandates specify that masks indoors need to be worn if 6-foot distancing can't be maintained between people of different households. But we know that airborne transmission may also be important. So the question finally is, should mask recommendations say masks should always be worn in public indoors, regardless of distance? And then a follow-up question to this is, should masks be worn while playing sports, vigorous sports? Many school teams are opting not to wear masks during the sport itself because it is not feasible. And so second question is, should they be requiring team players or activities coaches to insist that masks get worn?
Yeah, well, great questions. And those are the ones that we're grappling with across the country. We know that masks can reduce transmission. There's been some really interesting studies that have been done in China and in Taiwan and in Hong Kong, where mask use is done a lot. And they compared households that wear masks and didn't when they had an infected person in them. And they showed in those settings that masks could reduce transmission from household contact by 70%. And we also have some other investigations that have been done, like on the USS Theodore Roosevelt, one of the naval warships, where mask use was put into place, also reduced transmission on that Navy ship with infected sailors by 70%. So there's some good evidence mounting. We'll probably never have the kind of controlled trial that we have for vaccines that we would like for masks. Nobody's going to do an experiment with, here, you don't wear a mask, you wear a mask. We're going to try to infect both of you and see what happens. It's unethical. We know there's enough evidence now that masks make a difference, that they reduce transmission. By themselves, they're not perfect, but it's sort of like going out in the winter. You wouldn't go out with just gloves on. You go out with gloves, boots, and a jacket. So the masks are like the gloves, the distance is like the jacket, the boots is like keep your contact with other people short. And so those things all together add up to a warmer winter coat and better protection for the individual. So I was a mask skeptic at first, I must say, because the evidence really wasn't there, but I have come around from reading these studies and seeing what's happened. We had a mask mandate in Anchorage that went into place, and we saw a 15% reduction in the growth rate of SARS-CoV in Anchorage in the 2 weeks after the mask mandate. And that's without complete compliance and with a lot of people not wearing masks. So we have seen them work in our own city here. And that evidence is piled up in repeated places around the US too. So I'm strongly in favor of mask mandates. I think they can make a difference. And I think people, if they want to protect themselves and protect others, they should wear them all the time indoors when they're around people that are not in their household bubble, whether they think they're going to be within 6 feet or not, because you don't know. If you're in the grocery store, you could turn around the corner and bump into somebody, and you don't want them coughing in your face, and you don't want to cough in their face too. So it's an added layer of protection. And I think it's a good, sensible thing to do and a sensible thing to require, in the same way that we require seatbelts. We don't ask people to wear seatbelts only when they're going to get in a car crash. We ask them to wear seatbelts all the time. And that's the same thing with masks. With sports teams, we know that there have been a number of outbreaks in sports teams, especially those in close contact, and hockey teams in particular. They're close on the bench. They're bumping into each other on the ice. The ice itself, by being cold, there's not a lot of ventilation around it. There's some unique circumstances there. And we've seen repeated outbreaks in hockey tournaments here in Anchorage. We've seen them in Canada. We've seen them in Florida. Any place you put people indoor on a hockey rink seems to be an increased risk. And I think they should be wearing those masks. CDC does the same recommendation. If you have a cross-country running team or skiing team, and they can maintain separation, maybe not. You know, not all sports are the same, but for any that have close contact that are indoors, I think masks are a good idea.
Great, thanks for that. And a couple more questions are on this sort of prevention line. I want to scroll to make sure that I'm covering all these questions. The questions are about traveling during the holidays. So many people do have travel related questions. So what is your recommendation for safely traveling? And then here's a question from Hannah, a young person named Hannah. Why can't we have things like football and not theater during the pandemic? So I guess I'm going to separate those out a little more, because travel is quite different from football and theater. Let's maybe answer Hannah's question first, because that's more along the mask and sports line. So Hannah is asking about the difference between those group activities.
Yeah, well, that's a tough one. The reason we've had professional sports played is because they basically bubbled those athletes and they tested them like crazy. And if you followed that, many of them got excluded because they tested positive. The quarterback of the New England Patriots, Cam Newton, got tested positive and he missed a couple games or a game. And so they are doing really active monitoring among those athletes. There's no fans in the stands, or very limited. And in baseball, they bubbled them out. In hockey, they bubbled them. They put them kind of in these little enclaves when they were in their tournaments, and went to extraordinary measures that we couldn't do for high school athletes, and we certainly can't do at the university level. And you might have heard that UAA canceled their sports for fall and winter this year, just because the testing and the cost and the logistics of testing and traveling is just too much for a lot of these conferences to do. The thing about theater is that it's dangerous kind of for everybody at the same time. One is that you're crammed in a theater seat next to somebody. You could space people out, but the ventilation might not be good enough. And then the people on stage are singing or talking loud, and they are shedding. And if they are infected and are asymptomatic, they could infect the first rows of the audience. And so theaters all across the country, musical events, have seen what's happened with some of these just spectacular, awful super spreader events in a theater environment, and have just closed down and said, we're not going to take the chance. We can't risk it. We can't rehearse safely. We can't do our performances. We're just going to have to wait this out. And I mourn that. It's one of the things I miss the most about where we are right now, is that we can't have live music and live theater. And I hate it, but I recognize why it's done. And it's really for our safety and for the safety of the theater performers and the musicians themselves. So it's just an unfortunate consequence. And so Hannah, that's why it's worked out that way. I think sports we're going to see less and less of them until we get a vaccine. I just don't think there's a really good, safe way to do it, except for some of the sports like cross-country skiing where they're outdoors and really spaced apart.
Sure. Thanks for that. And now I'll take you on to the questions about traveling and holiday visits. Specific question, it's a general question of how do I protect myself while traveling over the holidays?
Yeah, well, the safest thing to do is to not travel in an airplane over the holidays. If you can get in a car and drive someplace, fine. Or, but to get in an airplane, you are taking a risk. There's no doubt about it. Now, airplanes, Alaska Air, I think, has still got the spacing where the middle seat isn't occupied, but you are in close contact with the people in front of you and behind you and one seat over. So you are immediately put in close contact with people and you don't know anything about their COVID status. 40% of people get this infection, don't have symptoms, but can still spread it to other people. And it's sort of mind-blowing that you could have an infection, not be ill, but transmit it to other people. But we know this happens. It happens with influenza. It happens with salmonella. It happens with a lot of other infections that we know a lot about. This is not brand new for COVID. The extent of it is just amazing, though. And so that means anytime you get on an airplane, you're rolling the dice. And so I don't think there is a safe way to travel on an airplane entirely. I have had people I know, family members of mine, ask how to do it. They put on a respirator mask, they put goggles on, they wash their hands, and they just get on and hope and pray that they don't sit next to somebody who's infected. And then they get to their location and then they quarantine and they get tested, and it's a big hassle. But if you're going to visit grandma and grandpa and you show up with a coronavirus infection that you got on the airplane and give it to them at Thanksgiving and you didn't have to be there, I just don't want to be in that situation. So I haven't gotten on a plane since last February, and I probably won't until I'm vaccinated. And that's what I'm advising people to do. If you don't have to get on an airplane, don't. If you have to go someplace, try to do everything you can to precaution up, get tested before you go, wear a mask, hope and pray. But I would just say don't. And this is going to be our coronavirus year. We're going to have to learn how to celebrate these holidays in a different way. And I miss my mother and father-in-law, and I miss my sister and brother, but I'm just not going to be the person who travels to them and infects them and kills them. I'm just not going to do that. So that's my take on it. Other people see that risk calculus different, and I respect that. And I know other people have different reasons for traveling. And the states themselves are taking this on. In Alaska, we had this travel policy to try to prevent people from coming to our state with coronavirus by requiring people to test and be quarantined. And we're going to see a lot more of that. You want to go to Hawaii, you got to get tested. Then you're going to quarantine. This more and more states are going to do this. So it's going to be harder to travel until we get people vaccinated and immune. It's just going to be disrupted. So that's my take on it.
Great. Thank you. And you segue perfectly into another question, which is asking, do you recommend for Sitkans who would like to obtain the required COVID test for Hawaii travel, do these Sitka tests meet the requirements to travel in Hawaii? And they're specific to that state, as you've stated. Every state has their different requirements. I was able to look up this information on behalf of the Sitka testing search, and if it's okay with you, I'll go ahead and share that, or do you want to?
Oh, please do. Yeah. I don't know the answer to this.
Yeah, the testing that's done in Sitka by search does meet the criteria for the state of Hawaii. However, we are not one of the trusted partners that they list on their website. The state of Hawaii has gone so far as to even name certain labs that they trust the results from. And the search Sitka testing, while it is done in-house and it does meet the criteria, for the testing does not, we're not on the trusted partner list for Hawaii. So the best recommendation from our medical staff was to travel to Seattle or another city en route to Hawaii. And there are numerous trusted partner labs within those cities where they could, again, if you wanted to build a day on the ground in one of these cities like Seattle or Portland, you could easily get a test from a trusted partner there. So that's the answer to that specific question. There's some other questions about testing, and I thought it would be good maybe to cycle into those. One question is the testing turnaround. You mentioned in your earlier presentation that the turnaround for testing in Alaska is 2 to 3 days. And in our region, sometimes it is a few days longer even. Does the turnaround mean the time of the specimen collection? Does turnaround time mean that the time of the specimen collection to the time that results are available? Is that what you mean by turnaround time? That's part A. I see you nodding. And do many specimens in Alaska need to be transported to another town to be analyzed in a lab? Do you have any overview on that, on how many towns have testing in town versus having to send it out?
Yeah, I don't know the specifics for your communities, but generally testing, which is pretty available in Alaska, but it falls into 3 categories in 3 locations. There is some testing that's done at the facility, and there are increasingly rapid tests that can be done that can give a turnaround of 15 minutes. And there's a whole batch order of tests that the state of Alaska is going to purchase and place in clinics in different places in the state. And I know the tribal health system has done some of this, where you could get a result fairly quickly. And these are not the gold standard super perfect tests that the state public health lab does, but they're pretty darn good. And they work really well with people who have symptoms. So there are some turnaround that you can get at the same hour that the specimen's taken. The specimen turnaround time I was referring to is sort of an average of the other 2 kinds of tests besides the ones done at a facility in your community. And those are the ones that are a swab that are sent to the state public health lab. And those are either tested in Anchorage or in Fairbanks. And those obviously from your community are going to have to be shipped, and then they're going to be processed. And so that's going to be a longer turnaround time than the ones that are taken at the testing facility at Lake Otis and Anchorage. So you just have a built-in transport issue there. And that's why there's that range for turnaround. And then some of the commercial labs, some of the commercial facilities, like some of the groups that are doing testing for travelers coming into the state, are sending their swab specimens out of state. And some of them are going to Cleveland or San Diego or other places like that. And those can take longer. So it's a really, it's a mixed picture depending on where you get your tests done. We are going to see this improve as time goes on. There's, I think, 165 different PCR tests that are now authorized by FDA, and there are companies falling all over themselves to get more testing available. And it's improving as time goes on, not as fast as we'd like it, but we are going to have better testing capability as time goes on that will help with this. And I expect that turnaround time will begin to improve and make it easier for us to get same-day testing. It's just, we're going to have to be patient with it. And not all these tests are going to be real good. Some of them are going to turn out to be clunkers, and we're going to have to get rid of them and figure out which are the good ones. So we're going to be learning as we go, as we've done all through this epidemic. We don't know the answers. We use science to try to figure out those answers and get closer to the truth. And people just have to recognize that that's what we're doing. And the same thing we're doing for healthcare too. We're improving as we go. It's not perfect, but we're working towards it.
Great. And that leads nicely to our next question, specifically about testing. Dr. Fauci recently stated, if you get a PCR cycle threshold of 35 or more, the chances of it being replication competent are minuscule. You can almost never culture a virus from a 37 threshold cycle, even 36. It's just dead nucleoids, period. That's the quote from Dr. Fauci. And the question from the listener is, why isn't the cycle threshold regulated and standardized? Why does the FDA recommend a cycle threshold of 40, which will almost always result in false positives? And what is the cycle threshold of PCR tests currently used in Alaska and at Search?
Yeah, wow.
That's a big one.
Interesting question.
For you. Yeah.
It gets to some of the nuances of this polymerase chain reaction test that we use to detect the RNA or the genetic material of the virus.
Mm-hmm.
So it basically picks up a signal that the virus is there. And, you know, when we become infected, the virus gets into our cells. And basically, these viruses are so weird. They don't really live and breathe like other organisms. Their whole purpose is just to hijack our cell machinery to make more viruses, and then they kick them out again. That's all they do. I don't know if they have any social life. They don't seem to replicate in any other way. And some people have even challenged when they're alive. So what we're picking up with those PCR tests is evidence of the genetic material of the virus. The old way we used to do this is we'd have to culture these viruses out. We'd have to get a sample from somebody's nose and then put it in a petri dish and try to grow it in a laboratory. It would take weeks, and it could only be done in specialized labs. And we hardly ever do that anymore because we've replaced it with these really rapid tests that can detect small signals of genetic material called PCR tests. And what the question is getting to is how many times the test has to be run on a particular sample. If you run it and you get a positive answer within 15 cycles, you know that there's probably a lot of virus there, but they keep running it on the negative ones to a certain limit, and then they stop. And the cycle threshold limit is sort of the limits of detection for that particular assay. And as I mentioned, there's about 160 different ones, and they all have a slightly different set of circumstances that they're run under. They use different primers and probe. They might use a little different polymerase. They might be run under different temperature conditions and slightly different circumstances. So they each one have to be calibrated to detect a certain level of virus within a given cycle threshold. That's why there's no one standard for that across the industry, because there's many different tests and each one has to be internally validated on its own. Mm-hmm. So Dr. Fauci's quote there is right, that the longer you run these tests, the fewer and fewer viral bits that they're likely to detect. And at a certain level, we stop looking and say there's probably no real virus there. In Alaska, the state public health lab runs a PCR test that has two targets. So it's actually two tests. And the first one that they use is a 37 cycle threshold. And the second one they use is a 40 cycle threshold. So by using two tests and having two targets, it increases the sensitivity and specificity of the test to the point where it's 100% for both of these. These are the gold standard tests that we use. They're highly reliable because they have two different targets and they're validated internally. So that number about cycle threshold, it almost never comes to that. The people that test positive typically test positive what we're seeing in cycle thresholds in the 20s, mid 20s, which means that there's enough virus there. So I'm not worried about that lower limits of detection. Those are super rare events. When people test positive, it's for both of those targets, and they're typically much lower than that. So that's what gives me confidence in the ability of these labs to run these tests.
Great, thank you. Next series of questions is about behaviors that are recommended for people who have already gotten COVID and recovered. So if a person has recovered from the virus and completed their quarantine, do you recommend they behave any differently? Is it safe for them to travel, for example? Do they still have to wear a mask and maintain social distancing? Can they still infect others?
Yeah, this is a big question. You know, if we have 10 to 15% of the U.S. population who's been infected, and are they now immune? The answer is we don't know. We have 24 instances where there have been documented reinfections, and these are at this real high level of standard. And let me tell you what we go through when we try to document one of these reinfections, so a person getting it twice. So the first infection, they have to have a sample of that virus that they save. And so the person gets that, they recover it, they had a PCR test that was positive, they had an illness. So that's the first infection. And there somewhere is saved a little sample of that virus. And then a month or more has to go by. And if that person gets infected again and develops a new infection with symptoms, as a PCR test that's positive, and they save a little bit of that sample, the scientists will take those two samples and they will compare them to make sure that the viruses are slightly different. Because it's possible somebody could just have the same infection, it would be lingering, and then they would just have kind of another second outbreak of the illness. So we've had 24 instances published in the world where they met this super high level. And most of the time, this isn't what's done because we don't save the samples, nobody's doing sequencing on them. We don't have that level of standard. But we have thousands and thousands of other reports of people, including my niece, who's an emergency room physician in New York City and is taking care of thousands of COVID patients. She got sick in April. despite wearing an N95 respirator mask and goggles and all that. She's just super careful, but she still got sick. And then 2 months went by, and she got sick again. And she had COVID. She knows what COVID looks like and what it feels like. And she is one of the many thousands of people that we're learning about that had clinical evidence of having COVID reinfection. Despite having gotten sick, she recovered, she went back to work and got sick again. And there's thousands of these cases. They don't have that high level of documentation with sequence matching and all those other things. But this is one of the things we're going to learn as time goes on. Why did my niece get sick from COVID a second time, and why do other people not? Is it something about her antibody response? Is it something different about the virus? How is this happening? And it's one of the mysteries right now. But the short answer to this very important question is yes, you can get COVID twice. And sometimes the second infection is worse than the first one. So if you had COVID and you recovered, you may be immune, but you should not act any differently than you did or should have the first time. You should still wear a mask. You should watch your distance. You should act as if you could get sick. And there have been some really, really tragic and unfortunate cases of people who got COVID once and got it again and either got sick or died or ended up in an intensive care unit. So you don't want that to happen just because you were careless. So unfortunately, we don't know enough about the immune response. And what we're hoping is that the vaccine is going to produce such great antibody that we're going to have long-lasting infection protection from these vaccines. And that 94% protection that was reported for the Moderna vaccine included people getting, not just getting infected and having a positive COVID test, but there was a group of those people who ended up with severe disease, were hospitalized, went to an ICU. And for one of those vaccines, none of the 15 people that we know about so far that got that level of sickness, none of them had been vaccinated with the real vaccine. They all happened in the placebo group. So as time goes on, we're going to learn lots more about how these vaccines work. Right now, the evidence is really good, and it will accumulate over time. When we vaccinate those 20 million healthcare workers, we're going to be following all of them and to see what the infection rates happen in those people and how much protection we can really expect under real world circumstances. And I can guarantee my niece is going to be one of those people lining up to get vaccinated.
Excellent. A related question this is actually a three-part question, so I'll say all three, and then you can take it apart one at a time. From a phylogenetic perspective, how many mutations of the virus are there? Are there stronger strains of the virus worldwide? And does the virus take genetic information from a carrier as it is passed on? So, big
Great questions.
Yep.
These viruses, like all organisms, mutate at a certain rate. RNA viruses mutate a little faster than other kinds of viruses because they don't have the spell checker built into their system to prevent mutations that might happen. So they do mutate at a predictable rate. In fact, that's how we can tell where these viruses have spread, is that we can look at viruses from France in May that were different from the initial outbreak strain in China, and then track those to the United States and see where viruses were introduced into the US. So those are minor little changes, but they haven't changed the very nature of the virus, how it attacks our cells, how it replicates. Because if that happened at a big level, the virus would stop being competent and wouldn't infect people. So we know that there's 7 different kind of big strain groupings of these SARS coronavirus 2s that have been identified worldwide. 6 of those have been identified in Alaska. So we have 6 of the 7 kind of major mutation groupings based on genetic sequencing. So we've gotten virus from all over the world in Alaska. Clinically, these don't appear to make any difference at all. There is one strain that has one mutation that has been thought to maybe make them more infectious than the original strain. So they might spread a little more easily, but they don't appear to make people any sicker. So this is something we'll learn as time goes on. These things tend to shift around a little bit. But from a practical standpoint, The important part of that is that the antibodies that are produced by the vaccine recognize a part of the virus that is conserved across all of these virus strains, so that this little spike protein that sticks out that makes the crown on the coronavirus, that has been remarkably stable in all of these viruses and no mutations in the important areas. And that's what the vaccine manufacturers have targeted to make their antibodies go after. And so that's the good news, is that the vaccine should be able to handle these minor changes in the virus that are happening in other parts of the sequence, then, and keeping that part that we're targeting, that seems to be very stable. So long-winded answer, sorry, but that's what I know about that.
No, you did answer the question. The last part though is, does the virus take genetic information from a carrier?
Oh,
yeah.
Not that I know of.
Okay.
There are retroviruses that incorporate themselves into DNA. HIV is one of those, and sometimes they borrow things. Not that I'm aware of. That I think this thing operates on its own, does its own mutations, and it's an RNA virus, for example, and our genetic code is DNA. So there's some big differences in how the sugars align on the backbone that probably would prevent that from happening. But somebody who knows a lot more about genetics could probably give a more elegant response to that, but not that I'm aware of.
Okay, great. Here's a question, or a series of questions about, you mentioned that some people are asymptomatic and while others get very, very sick. And is there a link, understanding that each person is different and we all have different bodies and responses, but is there a link between how sick you get or whether you're asymptomatic to a load of virus? So if you're infected with somebody sneezing directly in your face, I'm paraphrasing now, but if you get a lot of virus all at once, or if you just get a little bit of virus, does that seem to affect how sick you get? Do we know anything about how that works?
Yeah, it's a great question, and it's one that's been asked a lot in the scientific community. There's some good evidence that this dose effect holds for other viruses. Influenza, for example, there's been some really good studies in past influenza outbreaks that show that if you get a large dose of virus, you're more likely to get sick and sicker. And so people have looked at that for SARS coronavirus and tried to understand that. I think the jury's out on that still, and we're gathering more information. But there have been some really interesting studies that show that people wearing masks tend not to get as sick. And I think those are really fascinating because that might be a reduction in the dose, but I don't think it's conclusive yet. So I think we're going to have to wait to see about that. There are other factors, though, about that influence how sick you get. And people on the program here probably are already aware of those. But we know that the risk of getting hospitalized and the risk of dying increases with age. It also increases with other health problems that you have, heart conditions, diabetes, high blood pressure, immune deficiencies, other things like that increase your risk of getting really severe SARS-CoV. But that doesn't explain all the illnesses. So a study came out from CDC over the summer that looked at deaths in the United States, and 40% of the people that had died from COVID in that US study did not have any underlying health conditions that would have singled them out as being high risk. They might just been age-related factors. So we do know that there are people who have died from COVID that did not have what you wouldn't have looked at them and said, oh yeah, you're probably going to have a problem with the infection. Just otherwise healthy people who, just for whatever reason that we don't understand, succumb to the infection. And all these deaths are a tragedy, but when you have a young person dying who, their life is cut short, it hurts everybody, and they're all painful to see. So there's a lot we're going to learn about this. Hopefully we'll get the vaccine going and we can learn without many more deaths, but there's a lot of factors that fit into that. Some of it might be related to the infectious dose and just how well the virus is replicating in your body. Some of it might be related to your own immune system and how overactive it is. That's why they're using steroid hormones, corticosteroid hormones, to try to tamp down the immune response, and that seems to be helping. President Trump got treated with that. And so that's becoming part of a standard approach, is try to slow down our own body's immune response, And we know this happens in other virus infections. It's not necessarily the virus, but our response to the virus that is more dangerous. So these cytokines are a chemical released by our own immune system that can ramp things up and cause all sorts of problems in our body, blood system, and other problems. And that may be part of the mortality. And then there's this other factor related to clotting. This virus seems to induce clotting so that in our small blood vessels, they get little blood clots to develop and shut off blood flow to the kidneys, lungs, and heart. And they're almost like little heart attacks caused by the virus or response to it. So those three elements fit into this very complex picture that is really hard for us to predict right now who's going to end up with a bad infection. So because of that, I know older people are hunkering down and trying to avoid infections. I know people with health conditions are doing that, but really it could happen to anybody. So that's a reason to protect yourself and protect those around you, is because you don't know if you have the infection or spreading it to somebody else, and if you might be one of those unlucky people who just ends up with a really bad infection, even though you're young and healthy. So
Great.
that's part of the mystery of all of this.
Great. Follow-up question to that. Is there any evidence to suggest that blood type has anything to do with susceptibility to the virus or reaction to the virus? And the question asker says that they saw articles this year about people with type O being less likely to get the virus.
Yeah, I saw this came out early in this epidemic that blood type A positive, mine, was at higher risk. So I took particular note of that. And I think it remains to be determined. It's something we're going to continue to examine. These are all observational studies. So you look back at groups of people and say, did this group of people have higher risk, and was it their blood type, or were they, or all these other factors? And you can imagine you're trying to balance, well, was it their age, or the fact that they had diabetes, or were they in a population where these were really common blood types and they just had a lot of infection in their community? And that's really the causes that there was widespread transmission. So really complicated to tease all that out. And we're just going to need a lot more scientific evidence, because I've seen reports on both sides of it right now. So I don't really know. And, it's interesting, and eventually we'll probably have an answer, but you can't change your blood type. So it's one of those questions that's less important to me than some of the other things that we can modify. Like we can modify our risk about where we go out in public and whether we wear a mask, whether we wash our hands, the people that we bubble around, all of that you can change. You can change your risk for it. You can't change your blood type. So it's interesting, but certainly not as important, I think, compared to the things we can make a difference with.
Sure. And a related question to that is, in Sitka and in the rest of Alaska, more infections are occurring in people ages 20 to 29 and 30 to 39 than any other age group. Is this a result of behavior, or does the virus now just favor these groups?
We have seen that the virus is capable of infecting all age groups. Little kids under age 10 tend not to get, under the age of 10, they don't get as sick. We don't know why. We'll hope to figure that out at some point. But they can still transmit to other people. And it's been shown in some unfortunate events that even young kids who don't get infected very easily can still shed the virus. You can find it in their nose and their nasal secretions, and they can transmit to others. The same is true for 20 to 30-year-olds and 30 to 40-year-olds. They tend to get not as sick. They're certainly not hospitalized as frequently, and certainly don't end up dying as frequently. And that's the good news. But the evidence from all across the United States is that it's very easy for people to get infected with this virus, and it's easy for people to shed it and transmit it to other people. So younger folks, that's great, but they have become, by becoming mostly infected and more social than perhaps older folks, have become the spreaders of this virus all across the country. And I worked for the University of Alaska, and we took special attention to the residence halls and dormitories in the university for possible places of transmission. Just because of this, we saw the outbreaks in college campuses and high school classrooms and other locations where people are not following necessarily the recommendations and getting together and hanging out and shedding the virus to each other. So, and bringing it home to their parents and grandparents. And that's the unfortunate part of it. So I don't think young people are more likely to become infected by their biology or anything in the virus. They're just more socially active and tend not to take the same precautions that older people do because of their risk group. We do have some information from household studies. This really interesting report came out of Tennessee and Wisconsin, where they followed and continue to follow households where there was an index case in the household. An individual was the first person in a household that became infected with coronavirus. And then they followed those families over time and those people during their isolation and quarantine period afterwards. And they just published this report on 101 of these in the state of Tennessee and Wisconsin. And they'll find more of this, but the preliminary results show that the transmission rate in those households was 35% in the household setting. So that gives you an idea of a risk a risk of transmission of if you have an infected household member and they're isolating with you and you're not taking special precautions, there's about a 1 in 3 chance of transmission. A similar study was done in Singapore where people commonly wear masks in the household, and they showed a 70% reduction in transmission in those households. So that 35% transmission risk, my risk would be 1 out of 3 of getting infected if I had a household member who had COVID and I lived in Wisconsin or Tennessee. If I lived in Singapore where people were using masks in those household settings, the risk dropped to 1 in 10. So to me, the evidence is piling up. It's piling up that these masks make a huge difference in reducing risk of transmission in household settings where we know it's a real high risk setting. And so I just think it's inescapable that masks make a difference. And we need to convince people to wear masks in any way we can, whether it's mandates or cajoling people or just begging people like the governor did a week ago, please wear a mask, save a life, be a hero, don't transmit it to your family. And the folks that are joining us tonight, Martha, are probably already lined up that way, but if you could spread that message to your family and friends and be like dandelion seeds to the wind, we can reduce transmission in Alaska by 15%. We can turn this thing around the other direction. And then when the vaccine gets here and we start to vaccinate healthcare workers and we get vaccination to our older people and to the people at high risk, we can turn this around and get back to normal life. But if people ignore the advice, it doesn't matter when the vaccine comes, we're going to end up, unfortunately, having a lot more Alaskans die or end up with long COVID syndrome or lifelong disabilities. And we just don't want that. So we're so close to where we could really turn this around. And it's really going to depend on a groundswell of people saying and doing the right thing. So that's my plea with fellow Alaskans. Let's do that. We can do it. We can beat this.
Just a few more questions, Dr. Hennessy. Questions about bubbles. What are the best practices for creating bubbles? And so, following up with some of the other questions are like, can you have one person in your bubble? Can you have more than one person in your bubble? What is your recommendation on that?
Yeah, smaller is better. People of like mind in a bubble is better. So, so I'm 60 years old. If I bubbled with somebody who was 20 and who was going out to bars, that would be a bad idea. But if I have people in my bubble that are similarly cautious and aren't going out into a workplace and are being really careful about mask use and hand washing, I might bring them into my bubble because I know what their practices are and how careful they are. If you want to form a bubble, one way to do it is to test people. And what I recommend with that is to get 2 tests. So let's say, Martha, you and our families, we're going to get together. Let's all get tested today, and we're going to kind of quarantine ourselves and be careful. And then let's get tested again in a week, just in case today we're incubating the virus and we wouldn't come up with a positive test. In a week, those 2 tests separated by a week gives you really strong assurance that you're not infected right now. And that's what we used in the dormitories at UAF, UAA, and UAS in Juneau. That's how we got people safely into the dormitories and residence halls. So now you can be in my bubble. We both tested negative. and we can hang out. And if you continue the same safe practices, I do that, maybe we can get together and have a dinner party where we're staying 6 feet apart, wearing a mask, hanging out, and start to resume normal life. That's what I know a lot of people have done. That's how people are planning for the holidays in some settings. Let me tell you a story about my daughter. So she lives in Los Angeles, lives with a household of people, was going to come visit us. So we got her tested. She came up here. She was being really careful on quarantine. We put her in the camper outside my house, came up in the summer, and we waited, got her tested in a week. The day she got here, she found out that her roommate's boyfriend started having symptoms. And we realized that even though my daughter was really careful, she was rooming with somebody who had a boyfriend who expanded her bubble a lot. So my bubble was no longer just my daughter, my family, it was my daughter's bubble and my daughter's friends' bubbles. And so you start to expand that out. And we hadn't been careful enough with that. Fortunately, nobody got sick. We did okay, but it gives you an idea of what you need to think about. It's not just who you're hanging out with, it's who they're hanging out with too. So that's the considerations I'd have people do.
Awesome. We just have a few minutes left and we have just 2 questions, hoping we can get these answered. The one question is, has the vaccine trial been tested on adults with medical risks or just healthy adults? We can answer that quickly and then we'll go to the final question.
Yeah, both. So they didn't exclude people with health conditions. In fact, they encouraged people of diverse ethnic backgrounds, older and younger people, people who had COVID, if they had underlying health conditions, that was okay. Because of the way they did it, they brought them into the vaccine trial and then they randomly assigned them to placebo or vaccine. And they wanted people that looked like the rest of the US population. So yes, we'll learn a lot about people who are at risk from those vaccine trials. They didn't just do healthy people. Good question.
And then final question, I think it'll wrap up our session very nicely. Have you run a comparison of the psychological, emotional, and economic costs, injuries, and deaths caused by the disease versus the psychological, emotional, and economic costs, injuries, and deaths caused by the COVID measures?
Wow, well, that's a really interesting and thoughtful question. You know, it really comes down to this harm reduction. And a lot of people have raised this question, I think legitimately. Are we doing more in our response to COVID that's hurting people, they're hurting our economy, et cetera, people's psychological well-being compared to the damage that the virus itself has done? And the kind of calculation that's being asked by in that question will not be able to be done for years because we don't have ongoing immediate data about what psychological harm was caused by COVID versus the economic impact of government measures. So it will take time to answer that question. So it's a reasonable question to ask, but what we do know is that we've had 250,000 Americans die and more coming. And those are people that would not have died if this virus had not visited us. And what we're trying to do with all these measures that are restricting movement or encouraging people to distance and take on these activities is to prevent more illnesses and deaths. And one of the things that we're trying to prevent, which is one of the things I started with, is if we have to prevent our healthcare system from being overrun with COVID sick persons. And we have to protect our healthcare workers so that they're available so that when you get in a car crash or you have a heart attack or your baby's coming, you have healthcare workers who are there to take care of you. And so the way we do that is we limit the number of COVID infections by following these steps and save our healthcare system. And we are in danger of potentially overrunning that. It has already happened in the United States and New York City. It's already happened in Italy, in Spain, and in France. And that is the standard that I use, is we have to control this to the point where we don't overwhelm our healthcare system. Otherwise, the calculus that was described in that question will be overwhelmingly in favor of the virus. And we'll have just so many people that will suffer as a result of that. So that's my standard. Let's not do any harm to people. Let us protect our healthcare system. You know, most of the economic harm that's come about in this pandemic is not a result of government action. You know, the shutdowns that we've had in Alaska were actually relatively short-lived. Most of the economic harm, the lack of tourism, was not because we told tourists to stay away, is because they stayed away because they were fearful of the virus and coming and traveling. And people have stopped going to businesses because they didn't feel safe. And until we get the virus controlled by vaccination and getting us immune, people are going to continue to be afraid, rightfully, and our economy won't recover. So control the virus first, then our economy can come back and people can start feeling safe again.
Okay. Thank you so much. You answered an amazing number of questions. We really got through a lot of material, so thank you for that. Lily, I'm going to hand it back to you if you're there to sign us off from Raven Radio. And thank everybody who was on the session today. It was you helped us all to learn a little bit more tonight.
Thanks, Martha. Great job moderating. Excellent questions from the panel. I appreciate everybody's contribution. Thank you for having me here tonight.
Absolutely. Thank you, Martha. And thank you so much, Dr. Hennessy. This was super informative. And thank you to everyone who asked questions. We got lots of good questions, both in advance and in the Q&A box. So thank you so much. A lot of this info was hot off the presses. So that was pretty exciting. I feel like I know more about vaccines than anybody I know. And I wanted to shout out Miss McCutcheon's students at the Adventist school who submitted some questions themselves. If you want to share this information with your family and friends, please do. Like Dr. Hennessy said, you can be like dandelion seeds in the wind. I loved that metaphor. The recording will be available via the registration link. So this webinar is available on demand for the next couple weeks. And then we will move it over to our YouTube channel. So check our website if you want to find the recording. If you have any issues, email me at development@kcaw.org. I also welcome any feedback about the event, or again, if you have any issues accessing the recording, technical issues, anything like that. We will have one more of these events, so stay tuned on our website for info on that. It will probably be early 2021. And once again, thank you to our members and the Alaska Community Foundation for enabling us to support the public in this way. Once again, if this event inspired you to become a Raven Radio member and you aren't already, please visit kcaw.org/donate. And again, reach out to me at any time at development@kcaw.org. Thank you again so much, Dr. Hennessy. This was a really great event. Thank you, Martha. And thank you again, everyone. Have a great rest of your night.
Bye.
Thank you.